Good afternoon, and thank you for joining us for the National Conference of State Legislatures Public Health Webinar Series. As of yesterday, over 290,000 people in the United States have died from COVID-19. But did you know that last night, FDA's Vaccine and Related Biological Products Advisory Committee has recommended that the Pfizer COVID-19 vaccine be approved? Our webinar today is titled State Planning for Distribution and Allocation of the COVID-19 Vaccine. My name is Tara Johnson, and I'm a program director in NCSL's health program, and I will be your moderator for today. Before I introduce our speakers, I want to review a few housekeeping items. Today's webinar platform is for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free to type your questions at any time during this webinar. To begin building some comfortability with the chat function, and also to see who is on the line today, I invite you to type in the state from which you are calling now. We will use the chat box for any questions during Q&A and after our speakers are done presenting. I want to briefly mention the resources. Above the presentation, you will see a couple of tabs. One is labeled Resources, and here you can find and download a PDF version of the PowerPoint presentation, as well as some other handouts. We have a lot of information to communicate today, and I suggest downloading the PowerPoint presentation now in case you'd like to refer back to them. Another tab is labeled Speaker, where you can read the full bios of today's speakers. Today's webinar is being recorded and will be available on our website within a week. I would like to thank the Centers for Disease Control and Prevention for their support of this webinar. So first, today you will hear a national overview and update on the COVID-19 vaccine from Dr. Nancy Messonnier. Following her presentation, you'll hear from Eric Skinner, NCSL's in-house expert on vaccine policy. Then we'll hear from a panel of two state experts, Stacey Hall and Christy Gray, who are leading the vaccine distribution planning in their respective states, Louisiana and Virginia. Then we'll end our time with Q&A from the audience. So we're here today to talk about how CDC and states are planning for the COVID-19 vaccine distribution and how states will allocate the vaccine while there are limited doses available. In terms of context, one thing that's important to know is that a lot of time and expertise has been put towards creating a national framework and guidance regarding the allocation of the COVID-19 vaccine. The National Academy of Medicine worked with a group of experts from around the country to create a framework and provide guidance. And their guidance is over 200 pages long. This slide is a very abbreviated version of how states could decide to implement allocation within various phases. In addition, the CDC released a playbook for jurisdictions, and that link is in the resources, which it breaks down further considerations for states. In the middle of October, all states and US territories submitted a draft plan for distribution and allocation. Each jurisdiction has taken into consideration what groups to prioritize and how many phases to include. Our colleagues at the National Academy for State Health Policy recently released an analysis on the state plans, which you can access through the link on this screen. And you'll see the state variations in terms of the number of priority phases and the different groups of people who are prioritized within earlier phases. States took into consideration the number of people they have in congregate facilities, certain populations like types of essential employees, and populations that may be more at risk of severe illness from COVID-19 and or health equity considerations. These priority groups on the screen are in one of the earlier phases before the general population in some or all of the state plans. One question we've been getting at NCSL is how is the legislature involved in the plans? And are members of the legislature, both legislators and legislative staff, in a priority phase in the state plans? From our analysis, at least 16 states specifically identify legislators, the legislature, or government leaders, or government employees that may include legislators and legislative staff under essential workers in a priority phase or in some part of a planning capacity. We saw at least 10 state plans include members of the legislature on task forces or work groups, or are a part of their communication plan around distribution. 7 states include the legislature or government employees that may include legislators and legislative staff in a priority phase. I will note that this is information that we gathered from draft plans, and just because the state plan didn't specifically list legislators or legislative staff does not mean that they have not been consulted in the planning or that they will not be included in a priority phase. If you're interested in learning more about the legislative role in your state, please reach out to your state immunization manager or state health official. Next, we will move on to our presentations by experts. First, we'll have Dr. Nancy Messonnier, the Director of the National Center for Immunization and Respiratory Diseases at CDC. Dr. Messonnier will provide a national overview and describe the challenges of the vaccine distribution during a pandemic. She does need to hop off after her presentation to attend an urgent ACIP meeting, so if you do have a question, please put it in the chat box during her presentation. I will hand it over to Dr. Nancy Messonnier. Here. Dr. Messonnier, can you hear me? Okay, I apologize. There's just a brief delay here. It looks like she's on. We're just having trouble hearing her. While we get that sorted, I'm going to hand it over to Eric Skinner, who will give a very brief presentation, just a few minutes, on considerations for state legislators. So Eric, I'm going to hand it over to you, and then we'll have Dr. Nancy Messonnier next.
Great. Thank you, Tara. I've moved us forward in our slides. So thank you and hello, everyone. I'm glad to be speaking with you all. As Tara said today, I will very quickly walk through a few bills related to the COVID-19 vaccine and give you all a sense of how state legislatures have been involved in this issue. So here are the 3 bills. I picked these bills as a representation of what we've been seeing through our legislative tracking. And the title here says it all, really. It's payment, workforce, and documentation. So our first example is from Maryland. Their legislation requires public and private insurance companies to cover the vaccine. So there have been some federal actions like the CARES Act and even the ACA that appear to ensure the same thing. But there is certainly a state legislative role in insurance coverage, and it has been an area of state action. And our second example here is from New Hampshire, which authorized pharmacists to administer the COVID-19 vaccine. And pharmacists' authority to vaccinate has really been the bulk of the bills we've seen on the COVID-19 vaccine. And you may be looking at this New Hampshire bill wondering why addressing pharmacists' use of vaccines on the state level is necessary, especially given the HHS rule in August authorizing pharmacists to administer FDA-approved vaccines. But that rule may expire, and we've heard also even just this week from a state that had to amend their administrative rules in light of that HHS rule. So sometimes there are some clarifying actions. And finally, we have Minnesota. Minnesota, they passed a bill to add COVID-19 vaccine to a list of vaccines that must be documented in the electronic health record when administered by a pharmacist. And on this slide, you'll see about pharmacists and vaccines. But what I really want to point out here is alignment with CDC vaccine recommendations. So the first example from North Carolina allows pharmacists to administer the flu vaccine within CDC guidelines. So one vaccine, follow the guidelines, that's simple enough. The second example from West Virginia is similarly written, but it allows a pharmacist to administer any vaccine so long as it is in line with CDC recommendations. So the reason I highlight these 2 bills and point out that distinction is because the second bill may authorize pharmacists to administer the COVID-19 vaccine, especially now that CDC's Advisory Committee on Immunization Practices has recommended the COVID-19 vaccine for frontline healthcare workers and residents in nursing facilities. So I say may authorize because I'm following a line of logic here and not state statute in every state. There may be other relevant parts of the code or administrative rule. So if you have a statute written similarly to the examples here, it may be worth reaching out to your immunization program to learn more. And there are other ways that state legislators can get involved in the distribution and allocation efforts beyond just authoring legislation. They can share highlights in the state plan and point out areas of federal and state alignment to both stakeholders and the public. And as Tara mentioned, they can also be included in priority vaccination groups and also be included in the task forces, commissions, and committees that are determining priority groups and more broadly conducting the state distribution planning. So that is my time. Please reach out to me if you have any questions. My contact information is on the screen. And thank you all for your attention. And I'm going to hand it back to Tara to keep us moving. Thank you.
Excellent. Thank you very much, Eric. And we are just getting a few things fixed on our end in terms of technology here. So I know Dr. Nancy Messonnier is calling back in. And I believe just got the phone number there. So while we have a minute while she dials in, I see a couple questions have come through the chat box. One question being, how are jurisdictions approaching mandatory vaccination for different groups? And I know, Eric, this is a question that we have gotten related to legislation. Could you quickly answer what you've been hearing about that?
Yes, absolutely. Thank you, Tara. So we've seen states address it on both sides, whether that is limiting the Department of Health's ability to issue a requirement, or whether whether or not the state issues a mandate. But what I will say is that we haven't seen a lot of legislation and nothing has passed yet. So I'm happy to provide. I know that New York is considering a bill for, I believe it's long-term care residents and workers. But I'd be happy to provide those bills and get into it a little bit more. But we just haven't seen much on it to date, but we're definitely watching.
Excellent. Thank you so much, Eric. I believe Dr. Messonnier just joined us. Dr. Messonnier, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, I can. Excellent.
I'm sorry for the technical difficulties. I can see you too.
No problem. That is just a part of how 2020 is going this year. Well, thank you so much for being on. I will hand it right over to you because I know you have limited time. And thank you in advance for your presentation.
Okay, well, I'll just launch right into this. I appreciate you all taking the time. It is a quite busy Friday afternoon, as it has been in this season. And I know that you all, like I, am anxiously awaiting the availability of the first COVID vaccines. You know, with so many cases and deaths still every day, this vaccine really does offer a light at the end of the tunnel. But there are some complexities and considerations with implementing of a COVID-19 vaccine that make it different from routine immunization. We're building our vaccine implementation plans based on what we do routinely in the United States every year when we, for example, distribute 80 million flu vaccines. But there are some differences with this vaccine that have really made it important for us to modify our plans. So first is the variant cold chain requirements, especially the first vaccine, which our advisory committee is discussing now, the Pfizer vaccine, requires storage in ultra low cold temperatures. That's not something that every provider has. In fact, very few providers have it. So it really has meant that we've had to change our operations. the need for socially distanced vaccination practices. Just like for flu vaccine this year, we certainly don't want people congregating waiting for their vaccine. And so that's meant that at the administration sites, they really have to schedule people out so that they come in a socially distanced way. There will be, at least initially, some limitations in the availability of vaccine, and we expect that stage of limited vaccine availability to actually last for a couple months. And that's really meant that we, working with the state and local health department partners, have had to do some hard looks at prioritization. The initial vaccines, the Pfizer and the Moderna vaccines that are both being considered right now by FDA, are mRNA vaccines, but they're not interchangeable and they both require 2 doses. That means if you get your first vaccine with the Pfizer vaccine, you have to get your second vaccine at 21 days later with the same vaccine, and the same with the Moderna vaccine. But one of those vaccines is 21 days, one is 28 days, and it's really important that you get the second dose. So we've really had to put in lots of measures in place to ensure people know they need to return and know which vaccine they should get. Vaccine efficacy and adverse event profiles do differ in different populations. And the implementation of the program for healthcare providers will especially need to consider the reactogenicity post-vaccination. All vaccines have side effects. The whole point of a vaccine is to mount an immune response. So it's not surprising that there can be some side effects. For these vaccines so far, those seem to be short. They last a day or two, and they're mild to moderate. There are things like a sore arm or people having fatigue, or especially after the second dose, fever. What that means at a healthcare facility, for example, is we don't want the healthcare facility to be vaccinating all of their healthcare personnel who work on their COVID ward the same day, and if everyone not feeling well the second day. And finally, safety monitoring is a priority in all of this, but we're especially anxious to ensure that we have safety monitoring ready to go as the initial vaccine launches so that we can gather that critical information. And I would say especially among long-term care residents. I heard a startling statistic the other day that really puts that in sort of perspective. If we vaccinate 100,000 long-term care facility residents on a Monday, by Wednesday, unfortunately, 80 of them will have passed away. And that's because, in general, people in long-term care facilities, skilled nursing facilities, are a little older and they're frail. And there actually are a considerable number of them that pass away of natural causes every day. It's going to be really important in the early days of these campaigns for folks to wait for the data, not to make assumptions about whether certain things are side effects of the vaccine. And finally, just like me talking to you, communication and education are critical to the success of the vaccine program. The next slide goes through some of the sequencing of the initial vaccine doses. CDC counts on our advisory committee on immunization practices to help us with these kind of decisions. ACIP, which again is meeting right now, is a group of independent scientists and one member of the community, and they are actually screened really strictly for conflicts of interest to make sure that they are independent. They have debated a number of issues around COVID vaccine. Right now, they're debating the possibility of recommending that first vaccine, the Pfizer vaccine, for use. But they're also the group that we look to help us with this issue around how to sequence prioritization. And the vote that they had last week was to recommend that the highest priority be given to healthcare professionals and long-term care facility residents. Healthcare professionals, because they have been on the front line of this fight against COVID since the beginning, and especially with the upsurge now, I know that you'll share my concern and desire to ensure that they can continue to do their jobs. Long-term care facility residents, because 40% of the deaths in this outbreak are due to long-term care facility residents who get COVID, and so lots of reason to want to prioritize those groups. As you can see, as we move out, there'll be further discussions actually next week in ACIP about the next set of prioritizations. And there are some difficult decisions coming up about how to make decisions about where to use those potentially limited supplies of vaccines. This is a figure that attempts to show the distribution of the Pfizer vaccine. And the reason I'm showing you this one is that this is the one that we expect should be going out the door as early as this weekend, and what we expect to be arriving in your jurisdictions by next week. So all the vaccines that are COVID vaccines are being centrally distributed. But one thing that's different about the Pfizer vaccine is that the Pfizer is not using the CDC central distributor, but it's basically being managed the same way. It's centralized ordering, and then the vaccine actually arrives at the administration sites along with their ancillary supplies. And in this scheme, you'll see that there are a variety of places where vaccination can arrive, but especially for the first vaccinations next week, most, if not all, jurisdictions are really prioritizing healthcare workers. So a lot of that vaccine is actually going to hospitals. And jurisdictions are also turning on their long-term care pharmacy program, where we have partnered with pharmacies to vaccinate in long-term care facilities, with the jurisdictions really choosing to opt into that system. This is a slide for me to show you a little bit more about safety. So the size and scope of the clinical trials with which these vaccines are being authorized are consistent with any vaccine that's licensed in the U.S., but yet we definitely feel the extra burden of ensuring that we have incredibly robust safety systems in order to monitor this vaccine. Now, in the U.S., we have probably the most robust safety system of any country in the world, but we've looked at our systems and really attempted to ensure that they are fully integrated and stood up for day one. So on the left-hand column, you'll see the systems that are ready to go and launch at the start of vaccination. These include our existing passive surveillance systems, theirs, the DoD and the VA systems, and our National Hospital Network system. But also we've added on top of that a system called vSafe, which is a text monitoring system that we're going to use to really enhance active surveillance. That is, we're going to follow up with everybody who gets vaccinated in those early days. They do need to opt in, and so we really are trying to get the message out of the importance of this to those who are getting their vaccines early. And as we move farther out from the initial vaccine, as we get to more general population-based vaccination, we have a variety of other systems that are already in place and that we're really enhancing. The idea here is that as large as these clinical trials are, there are things that happen when you vaccinate the entire population of the United States. So we really need these enhanced systems to do our due diligence, but also to really communicate to the American public how carefully we're reviewing this issue. Which gets me to the next question about the need to instill vaccine confidence. Now, in October, there was a poll. There have been a variety of these polls. And in this October poll, it does say that 58% of the general public said they would receive a COVID-19 vaccine. I think it's a reasonably good number, given that this was actually before a lot of the data about this vaccine was available. But you can see that the survey also says which factors weigh on folks' acceptance: concern about side effects, concern that the vaccine won't work, risk perception, and costs. Well, for these things, we really need to get out the word that, for example, we have good data that really makes us confident that these vaccines are safe. And frankly, if healthcare workers are confident in the safety, they can help us communicate that. The COVID vaccines will have no cost to the individuals. There won't be any copay. And even if you don't have insurance, the cost will be covered. These vaccines can help you get back to school and work. I can tell you that I am anxious for my teenage kids to get back in the classroom. And an important issue is that we need to make the vaccine easily available. We know this from all of our routine work, that if we can make the vaccine routinely available, even if folks have some questions or concerns about the vaccine, they're more likely to get vaccinated. And so especially as we start going to the spring, where we expect to have enough vaccine for the entire population, we really need to plan to have vaccine easily accessible to every corner of our communities. My final slide, sort of to wrap this all up, I want you to know that the availability of these vaccines is imminent. I expect that there will be vaccines in your communities by next week. and the initial supplies will be limited, and this is going to be hard for us. People are going to need to wait their turn, and these conversations about who is first in line are going to be complicated nationally and really very locally as well. There's been a huge amount of planning put in place, but there will be challenges, as there always are, and especially as we attempt to do something of really unprecedented size and scope. CDC will continue to work closely with all our partners to find solutions, overcome obstacles. Vaccines are an important tool to control the pandemic, but at least early on, we will all need to continue to wear masks, socially distance, and wash our hands until we can be sure that the vaccine's protection will be sufficient. And finally, I just want you to know that I understand jurisdictions are under immense stress, and they're implementing the COVID-19 vaccination amidst a surge in disease, incredible strain on the healthcare systems, and nearly a year spent fighting this pandemic. So we need to be cognizant of that, and from our part at CDC, we're really committed to doing whatever we can to help the jurisdictions. I believe that these vaccines are an important tool to control the pandemic. I think they are a light at the end of the tunnel, but it is going to take all of us working together to get where we want to be. I'll stop there. Thank you for your time.
Thank you so much, Dr. Messonnier. We really appreciate your time today. I think I've seen several questions come through the chat box, and I know you only have about a minute left with us. So I will just ask you one, and then the rest of them we will send to CDC following this webinar and get answers for our members. One question that came through from a legislator was asking if CDC will provide any national performance targets that states may use to measure whether the allocation and implementation of the vaccine are meeting these specific goals.
I think that it's going to be really important to work with states and jurisdictions to monitor a variety of things, and that includes uptake of the vaccine, but also, for example, wait times in clinics, and certainly the impact of the vaccine on disease. I think of those measures as quality improvement measures as opposed to sort of a target goal. My target goal is to get the whole population vaccinated, and the cadence may be slightly different in different jurisdictions. We'll be working with every jurisdiction to figure out what the obstacles are and to help them overcome those obstacles, and there certainly are lessons to be learned from neighboring jurisdictions. I expect in some communities, vaccine hesitancy will be a larger issue, and my goal is to anticipate that where we can, but when we encounter it, to really help jurisdictions figure out how to respond. Not a failure to encounter those problems, just something that we need to work our way through. And so, again, we will definitely be monitoring it across a wide swath of measures to look at all the parts of this equation from sort of the beginning to the end, and we'll certainly be transparent with jurisdictions about what we're finding.
Excellent. Thank you so much. And thank you again for your time today. Good luck with your meeting today.
Thank you.
All right. And I apologize we couldn't get to all of the questions in the chat box for Dr. Messonnier, but again, we will follow up with her and her colleagues at CDC with the various questions that we're not able to get to today. For now, we will move on to our state panel. And I'm thrilled to be here with Stacey Hall, again, the immunization director for the Louisiana Office of Public Health, and Christy Gray, who is the director of the Division of Immunization in the Virginia Department of Health. Just to kick us off, if you could please tell us about your role with the state related to vaccine planning, and what are key components of your distribution and allocation plan? Stacey, let's start with you. Stacey, I can't hear you. Can other folks hear you?
It helps if I unmute myself.
There we go.
I apologize. I'm Stacey Hall, and I direct the immunization program in Louisiana. We've been talking about planning for COVID vaccine when we first heard about this possibility. We've been committed to sharing what we've learned with others through the Association of Immunization Managers, and we really are trying to learn from others. And so that's why I was so excited to be here this afternoon and get to hear Christy's perspective too. We do have experience with COVID-19 that started with Mardi Gras last year. So, we had early intense outbreak, and ever since then, New Orleans has been especially serious about how severe the pandemic can be and how it can really impact their lives so closely and our ability as a society. Our strength in Louisiana really is our partnership. Because we have a lot of experience with emergencies in Louisiana, we know who each other are, and we have a way that communicates effectively and that people are able to step up and say, these are the resources I have, and when will I get my vaccine? So those are the main things we're hearing about. The governor's been so supportive in Louisiana, remains to be supportive. I do understand allocation of vaccine. We formed a vaccination action collaborative, and we have one work group specifically for prioritization and allocation. I really like calling it early doses of vaccine. There's going to be enough vaccine for everyone. It's just, what do you do with the first amounts of vaccine that come out? Everybody's a priority, but when there's not quite enough, how do we share that most effectively? Of course, we'll follow the guidance of the committee Nancy spoke about. The Advisory Committee on Immunization Practices will definitely fall in that framework. And then we're really looking at Louisiana prioritizing healthcare providers and personnel that are going to work in a COVID area, whether that's keeping the room, turning over for new patients, whether they're a physician, a nurse, or a respiratory therapist, people that are going to work knowing they're going to be exposed to COVID that day. Now, we have personal protective equipment, but those are the people exactly going into harm's way. After that, we'll expand in that healthcare arena, really our hospitals in Louisiana, to people that could be exposed through their daily. We've also included EMS and even EMS in fire services. And I think you're going to see that across the nation, that different people in different jurisdictions are going to take a little different perspective. First of all, that means we're still learning and we're still sharing. Secondly, it means we know what's going on in our own state. And so you may not have the complete visibility of what's happening, and we'll know where we need to direct resources so we can stay successful. Louisiana did choose the partnership with pharmacies nationally, and we've been so pleased about that opportunity. We have gotten all 287 nursing home and skilled nursing facilities ready to receive. In that category of long-term care, there's so many other providers that then will move into that area: intermediate care, developmental disability, residential facilities. There's just a whole lot more in that terminology. We've seen how this whole pandemic has impacted different groups, different racial and ethnic groups, and we have the opportunity with the vaccine to address some of those challenges. And we really are looking at health disparities very carefully. So that kind of is what I wanted to lead with, and I'm eager to get some of the questions in here, Christy.
That's great. Thank you so much, Stacey. And Christy, same question. Please tell us about your role and key components of your distribution plan in Virginia.
Good afternoon, everybody. Can you hear me?
Yes.
Excellent. Thank you so much for the opportunity. It's always nice to hear your voice. We don't get to see each other as often as we'd like, but it is nice to hear voices. So I am the director of the Division of Immunization here at the Virginia Department of Health. The Division of Immunization falls within the Office of Epidemiology at VDH. Our Virginia Unified Command, which was set up in March for response to the pandemic, it is comprised of not only the Department of Health, but several different Homeland Security, police, health equity, everything that really involves with our our government in order to ensure that it's responding to the pandemic and all the different considerations in the different phases that we've been going through. So our unified command had set up our vaccine unit in June 2020. And at the very beginning, we were a small and mighty bunch, as the information was less in volume than today. But we ensured that that unit included representation from several different groups that would need to be included in the response to be successful. So, of course, we had my division, immunization. That is where the entire state immunization program lies. And that also includes our state immunization registry, our VSC program, et cetera. We also have our Division of Pharmacy Services, which also falls within Office of EPI. And they are used primarily to order and send vaccine, non-VFC, non-public vaccine, and other programmatic drugs, medications to our local health departments. We also included our Office of Emergency Preparedness, our Office of Health Equity, and our Office of Community Health Services, which oversees our local health departments. We have 35 local health districts in our state, 33 of which are under direct contract or coordination through the central office, and 2 are independent. But we all work together to ensure anything that's being discussed or handled at the central level is dispersed down into the local communities. So our distribution allocation plan, as was mentioned earlier, we had followed the playbook that the CDC provided and have been constantly adjusting to the new things that have come up as a response. We are adopting ACIP recommendations for Phase 1A, prioritizing healthcare personnel and long-term care facility residents. We activated our long-term care facility pharmacy partnership with the CDC, and we are coordinating with our Virginia Hospital and Healthcare Association to partner with our health systems and hospitals to vaccinate not only their healthcare personnel, but also healthcare personnel that are not employed by them. We also are engaging our local health departments to do that, and some providers who have opted to be mass vaccinator and vaccinating people that are not their employees. We are currently reviewing our critical workforce in preparation for the future ACIP recommendations for Phase 1B, and are adapting to all the changes. But we're excited about the vaccine coming out, fingers crossed, next week, with the different meetings that are happening over the next few days for making that happen.
Great, thank you. I'm hearing a lot about coordinating with healthcare systems and pharmacies, private sector. And you both have mentioned in discussions that there were a lot of lessons learned, and that we have seen just from paying attention to the news how quickly this has all shifted this year. And so looking back when the distribution planning started to now, or even in just the last month, I'm sure a lot has changed. What has emerged as a key consideration that perhaps you weren't aware of at the beginning of this work? And Stacey, I'll pitch it to you first.
Okay, I guess vaccine hesitancy and just wanting to know more about the vaccine safety. And I don't think we did a great job of really explaining how this vaccine process has been abbreviated, that no safety step was missed, but that this was very, very financially risky because they developed the vaccine while it was in testing. And so I think some of those nuances, along with what you see, the vaccine committee for the FDA, the advisory committee on immunization practices, the CDC director, all of this is our world, and yet for others, it seems like, why are they stuck on a step? I do think one of our biggest challenges has been that the limited amount of vaccine that we're going to get. It's going to be really hard to make everyone happy, and probably impossible to make everyone happy with the amount of vaccine. The final thing would be really making informed decisions when there's still a guidance. I saw in the chat box, when are you doing teachers? Well, I know where we plan to put teachers, but I can't say where we plan to put teachers until I hear from the ACIP, and then the governor has input. So there are planning tools that we can switch and change and modify, but we're really waiting for this expert guidance to lead us into finalizing our plans. But I'm not sure anything will be finalized. I think we're going to continue to learn as we go along.
Great, thank you for sharing. And Christy, is there anything you'd like to add from your perspective?
Yeah, those are really good points, Stacey. We were very similar in that we kept telling people, yes, we would like to tell you, but we don't know yet. We're waiting for the ACIP recommendations. It would have been great to have had, especially vaccine-specific guidance, but due to the nature of this process, the vaccine manufacturers can't really make that public until it's been approved. So it really did make for a really rock and a hard place situation for jurisdictions who are trying to make plans and prepare providers, but don't have enough information to do it. I will say that we've had a lot of hard time hiring people. That it always takes, I feel like, 5 times more longer than you think it will to hire somebody. So that's something that we could have thought a little bit further ahead. But you just wouldn't think it would take so long to hire people. And I know, Stacey, you touched a little bit about this with vaccine hesitancy, and really ensuring that people understand that we're trying to get this vaccine out affordably, accessible, and equitably to everybody. One thing that we really set up early on was our Virginia Vaccine Advisory Work Group, and that was really a great, looking back now, is a really good idea, that we did it because we were able to really tap into the community to learn what, we're not doing this in a vacuum. We're learning what's out there and using or empowering people in that advisory work group to then go back out to the community and relay what we're at least know so far, get some feedback on messaging that we're considering or what other concerns are out there so that we can start working on it. And we really have tried very hard to ensure that all of our planning and coordination and implementation has been done using a health equity lens, and ensuring that we're thinking through not just, oh, this makes sense to me, but can a blind person do that? Can a deaf person do that? Can anybody that might have some barrier associated with it, have we run that through our team that looks for those kinds of things? Because it's not necessarily fault that I might not have thought of it, but I have a team whose purpose is to ensure they're looking through it for that type of lens, and we're considering everything we're doing with that effort so that nobody is really getting left out or left behind.
Thank you for sharing that. I'll ask one last question before we move to audience questions. I see 5 or 6 in the chat here. But just because we're getting this question from our members, does your draft state plan include the legislature and or government employees either in a priority phase, or are you considering, or your governor considering working with them in some capacity related to the distribution plan? And Stacey, we'll start with you.
Well, good. They are, initially it's state government that's in, we see in 1B as one we're looking toward including, but that would be state government that are involved in COVID response, not the entirety. I do think many involved in government will meet perhaps another priority group a little earlier, like perhaps they're over 65 or they have an underlying medical condition. I think there may be some overlap, of course, between categories. We did have 3 legislative sessions, this past legislative year, and we do realize how important that aspect of government is going forward. That's being addressed at the federal level, at the state level in Louisiana, and then at the local level by our Parish Office of Emergency Preparedness.
Great, thank you. And Christy, do you have anything you'd like to add from your state perspective?
And very similar to Stacey. We also had a session earlier in August, September timeframe. We are providing monthly updates to our General Assembly regarding our vaccine planning and implementation, and agree with how she mentioned about the different priority groups. And we're really just focusing on 1A right now and identifying people, but digging into our central work groups moving forward and looking to see what ACIP recommendations say.
Great, thank you. We'll go ahead and move on to audience Q&A right now. So feel free to add any more questions that you have for Stacey, Christy, or Eric in the chat box. And I have a list here, so we'll just go ahead and dive right in with a few of these questions. The first question I have, and it relates to a bit of what you just shared, but I do want to make sure we get to it. If you can identify where meat packing plant workers may rank in the vaccination priority groups. I know this is something that several states, have had outbreaks in the last few months or this year, and they have been hit hard with positivity rates. So just curious if either of you have them listed specifically in your plans. And Stacey, we'll start with you.
Sorry, Chrissy, I always just jump in, Christy. So in Louisiana, we've had issues with our crawfish packaging processing plants. So it's different wherever you are, but they are food producers, very important. That being said, there were initially outbreaks in those populations and of workers and in the setting. And I know a lot of things have happened since the early outbreaks to mitigate some of those issues. I think they'll be a bit later before it's open to the general public, but I really don't at this point see them quite as high with who would get so severe they would die. With us, that's probably going to move to home health, to dialysis centers, to areas that are still in healthcare. And I did see the question about what all does healthcare mean. And yes, we do have our dentists planning to vaccinate. They are on the ball and ready to go. And it's like, yay. But, I think we're going to just see meat packaging and those plants come a little later in outbreak response, probably phase 2.
In Virginia, we're still looking at our critical workforce and who would be categorized in that, and looking forward to the ACIP recommendations. So can't really commit one way or the other which phase right now.
Great, thank you for addressing that. I'm sure there were plenty of people on the line that were interested in your response there. We'll move on to the next question, which is interesting. There's a lot of talk about equitable allocation, and I've heard a lot of discussion about what's being done to address the negative reactions in minority communities. And in the state plans, we saw tribal communities and communities of color specifically mentioned in several state plans. I'm curious in your states what that conversation is and if there are any efforts specifically around minority populations. And to switch it up, Christy, we'll start with you and then go to Stacey.
Oh, it's a spicy Friday afternoon. So we actually just started a speaker series this week on community conversations with geared at specific minority groups. And several of us on the vaccine unit are taking turns attending each one of these, giving a presentation and answering questions, and it's been really successful. And this upcoming week, we're starting Tuesdays and Thursdays, separating fact and fiction, and really upping our public access to people and specifically targeting it at populations that we know have concerns and rightfully so. This week I was on the Latinx conversation, and it was very helpful to really not only do a quick presentation, but then hear from the public and their concerns, and there's not just myself, but other leaders that the population that you're targeting looks up to, other trusted persons in their circles that also speak and talk about, hey, this is why vaccination is important, and this is why it's important to me, and to really have that testimonial to speak to them, not just, the health department's coming and talking to you, but we really have partnered with the communities to engage and answer the concerns, because they are valid, and we want to make sure they're getting accurate information from us, and how we can ensure that they are making informed choices and with that accurate information, and not maybe some misinformation they're finding elsewhere.
I won't have very much to add. We did start by listening. We've done surveys, worked with groups that work in this area because they're trusted. We've had teletown halls, and we do have equity advocates already. The survey results, first concern was the safety of the vaccine, like almost everyone has that concern, but right up there, right under, was access to vaccine. So it really reminded us of how important that aspect is. They really would like to have services in different communities nearby where people live and work together. And they really want more non-traditional hours, evenings during the weekdays, Saturday and Sunday days on the weekends. So listening has been our first point, and we do have, some experts working with us in this field for the trusted messenger aspect.
Great, thank you for sharing your experiences there and the considerations in each of your states. A question just came through that I'm going to jump kind of down to, I think from the Hawaii legislature. Should governors and legislatures ensure there is consistent messaging with their respective communities that a vaccine will not be a silver bullet, and that masks and social distancing measures will need to remain in place for the foreseeable future? I know we've heard quite a lot about this from public health experts. And so curious if you can answer that specifically, as well as if the legislators in your state were interested in helping with communication strategies, and what might be their first step with that?
Consistent messaging is so important, and legislators are often a trusted resource for information. They're elected representatives. So we have reached out to include them. There's probably a lot more work that could be done in that area.
Christy, I would second that, that we in Virginia could be doing a better job at that. And the consistent messaging, our governor has been very discussed how it is not a silver bullet, but it's just another tool that we need to use in order to get there, and that it's not going to be an immediate thing that you're done and you can go do whatever you want. And I think it is important to set those realistic expectations so that we can get through the vaccination process and be successful at it, and not have and really reduce the transmission of COVID.
Excellent. Thank you so much. We just have time for one more question. And one question that did come through before the webinar started that I do want to make sure we touch on is the cost of the vaccine. And I know Dr. Messonnier shared there will be no cost to the individual, but I'm curious if there are discussions or needs in your state in terms of the cost for administering the vaccine. And Stacey, I'll start with you.
There are discussions about that, and I think it may have a negative impact on some of the providers we likely need most. You know, the complex storage and containment requirements for the Pfizer vaccine do present challenges to rural pharmacists who may not be able to even break even with offering this service. There are resources and a pool of funding to support that. We're not supposed to have anyone ask for funding up front, and the pharmacies are aware of not being allowed to turn someone away because of the inability to pay. But we need some of these resources to really call back for the second dose and things like happen later. And if you don't mind, I'll get one thing in after we let Christy speak just a bit.
Very, very similar in Virginia. We were having these conversations with especially our Medicaid office. There have been some unrelated but not necessarily directly related costs. For example, increase in transportation costs in order to get the vaccine for those that otherwise would not have needed that, and some ancillary supplies that are not included and such that Stacey had already mentioned. So we are working through that as well, and I'll go ahead and hand it back to Stacey.
Say we're keeping our eye on that vaccine, but let's don't forget the routine vaccines. You know, we have eliminated measles in this country, but that could turn on a dime. There's no need for us to have children dying from vaccine preventable diseases. So while the attention is on COVID, please keep focused at a local level on how you can support vaccine legislation and actions that really reflect the opinion of most people in the public. And also, it is important to allow medical or religious and philosophical exemptions. There are always going to be some portion of the population that don't want to participate, and you do need to allow that option for their individual freedom. I just wanted to get the plug in for HPV and measles and pertussis before we got too far away.
Thank you for that addition there. It's a good thing. We track that issue at NCSL. So if you do have questions about exemptions and routine vaccines, please do reach out to NCSL staff. We have a lot of information on those policies. I do want to wrap us up as we're just getting up to time here. This is one of 9 webinars in NCSL's public health webinar series. We have several more lined up over the course of the next few weeks on a variety of topics, including maternal mortality, suicide prevention, infectious disease, and adverse childhood experiences. For a complete schedule and registration details, please follow the link in the resources. Lastly, we'd like to extend a final thank you to our presenters. We greatly appreciate your expertise that you were able to share with our members during what is probably the busiest month of your careers. We'd like to thank CDC again for their support of this webinar. And following the webinar, there will be a brief survey. I do ask if you are able to please fill it out, as it will help us identify various ways to support your work on this topic over the next year. So thank you again for participating in today's webinar. And as a reminder, the recording and presentation slides will be available on NCSL's website within a week. Have a great rest of your day.